So colon cancer is the second most diagnosed colon cancer in women worldwide, okay? And in the US, it's the second leading cause of cancer death in women. And what is the number one cause? If you've come to my lectures before, you know that's because I harp about it all the time. Lung. It's lung cancer, okay? So colon, we're going to have it's second, with lung being first, okay? And 90% of the cases occur over age what, do you think? Yes. And as you see, as we go through this, we're building our case for our recommendations. When we have recommendations for colonoscopies, this is where all this comes from. We get to benefit from the years and years and years of all the poor souls that went before us and had their colonoscopies and things done, and that's how we get our recommendations, the research that they do, okay? So typically, and the way this happens is, colon cancer, they start out as something that's called an adenoma, which is a growth, okay? These adenomas can be in the form of a polyp, which is kind of a nice little glob, for lack of a better medical term, that sticks out from the colon. Okay, so if you've got your colon here, and a pen. Brown seems appropriate, right? Okay, so here's your polyp, and it's this nice little thing on a stalk, right? Those are the ones that the gastroenterologists are going to like, because when they go in with their colonoscopy, they can see that and they can get right around there and take it off, okay? Some of them, though, are flat lesions, meaning they're just on there like this. And that's why the colonoscopy is the gold standard for monitoring, looking for, screening for colon cancers, because you can directly visualize these, and we'll get to those in a little bit, okay? So most of them are these polyps, okay? And basically you start out with your polyp. I don't even know, can you all see this at all? I don't know if that's working. The polyp then gets bigger in size, okay? So you have these little ones, they start getting bigger in size. Then they start to change and they get what we call dysplasia. Okay, dysplasia is bad. Dysplasia means transferring over to cancer cells, okay? And then from the dysplasia, you go to cancer. Okay, this process right here takes about how many years, would you think? 10. Takes about 10 years. I'll try to use this pen. That's why for our recommendations, standard age we start at is age 50, and we do them every 10 years if your colonoscopy was normal. Okay, and we'll talk about that a little bit later in depth, okay? It's basically two types of polyps that we can get. One is called a hyperplastic. And these are terms that you hear when we get the colonoscopy reports from our gastroenterologists to do these. Or you might get a letter in the mail. You should get a letter in the mail. And it'll have these kind of words in there. Hyperplastic is benign. Very rarely will this transform over to cancer. The one we're most concerned about is called a tubular or a villus adenoma. Okay? These are precancerous. We're not saying that you have colon cancer, but these are the precancerous ones. Once you get these, then it takes you into a different category, then called a surveillance. Normal colonoscopy, every 10 years. Once we get an abnormality, though, then you go into a surveillance mode, and that's a little bit different schedule that you go by. Okay, and we'll get into that in a second, okay? Now, for risk factors. Thank you. We've talked a lot about, if you've come to my lectures before, we talk about the two different types of risk factors. Do you all remember what those types are? One is called modifiable, which means we could change it, and one is called non-modifiable, which just means these are what we're stuck with, right? We got the throw of the genetic dice, and here's what we've got, okay? So as far as our non-modifiable risk factors, this way, non-modifiable, what are those typically for all these things that we always talk about? What are those things that we just can't change? Our genetics, our family history, our age, what else?
Sex.
Gender. What else? The other big one here, the big four, are race. Okay, can't change that. And then some other things that we kind of throw in specifically when we're talking about colon cancer. One is inflammatory bowel disease, which is Crohn's and ulcerative colitis. Okay, these are autoimmune problems that affect the colon, and they put you at increased risk of getting colon cancer. The other one would be a previous polyp, like we talked about. And then another one that's sort of unique for us is endometrial cancer at age 50 or younger. I have a patient who recently is going to fall into this category. And it used to be a standard, if you got a breast cancer, endometrial, you got a colonoscopy. And it's not really the standard anymore, and I'm not really sure why. But that's something that your primary care provider will be looking at with you to determine what you need to have done, okay? And then, of course, modifiable ones are all the same stuff that we harp at you guys all the time about. Diet, exercise, weight loss, all those types of things, right? Cigarette smoking, alcohol use, all those kinds of things that are kind of bad for you in general for all these types of things. All right. Now, so that's sort of the brief rundown about colon cancer, okay? Another important statistic, if you're into statistics and numbers, a lot of women that I will say, this is the standard way this goes in the office. Have you had your colonoscopy? No, but my husband did. Well, good. You've harped your husband to death till he got his colonoscopy. Now, you need to go get your colonoscopy. It doesn't count. It's great that he got his, but that doesn't count for you, okay? And then the second thing that I will hear is, well, I don't have any symptoms. By the time you are symptomatic from colon cancer, 20% of those cases are already metastatic, which means by the time you get classic symptoms of colon cancer are significant weight loss, rectal bleeding, anemia. I've diagnosed multiple cases for patients who went into AFib first and then they got put on a blood thinner. Once they're put on the blood thinner, they start to bleed. And it helped us diagnose their colon cancers. But by the time you get any of that spontaneously, 20% of those are already metastatic, meaning most of the time to the liver. And then you're at a whole different stage for the cancer and treatment options, okay? So, how are we going to test for this? So, right off the bat, let's talk about the ones that we don't want to have done. So if you show up to the doctor's office and they recommend this, just go, no thank you, okay? So the ones we're not going to do anymore are a digital rectal exam. I used to do these a lot on my patients thinking, all right, we're already in here getting a female exam. It's awkward enough, it's bad enough, let's just go ahead and do it. We'll do the fecal occult blood card, you know, the little cards that we do. That's fecal occult blood. That's also on the do not do list, okay? This is the one-time card. Where it's just like we did the exam in the office, we did the card and tested it, because there's two words we look at when we're looking at testing, and those are called sensitivity and specificity. These two words have been the bane of my existence since I went to medical school, but I finally kind of understand them, okay? So what these do, these are very sensitive. Tests are sensitive for what they're sensitive to. I know that sounds kind of odd, but these tests are sensitive and designed to pick up blood. So they're very sensitive for picking up blood. You put the stool sample on there, you put a reagent on there, and it turns blue like my shirt, if there's blood present, okay? But where else is this blood going to come from? We're women, right? We've all had babies, we know what we're going through here. Hemorrhoids, right? Sometimes dietary things. If you've had a hamburger the day before, things like that, it'll pick up these things, and they're falsely positive, okay? So it's sensitive, but it's not specific at all. Basically, they're worthless. They're not recommended now by any of the big, like American Cancer Society or U.S. Preventive Task Force or any of these things, okay? And then another one is a barium enema. Barium enemas do still have their place in diagnosis of things, but not as a primary screening for colon cancer. From what I understand, these are hideous and worse 10 times than a colonoscopy, so you wouldn't want to sign up for that anyway. Sometimes these are done in addition to a colonoscopy if you didn't do your prep appropriately, or you have problems, which we'll talk about again later, and then you have this secondarily after going through the colonoscopy. But we don't see that very much anymore, okay? The tests that are recommended, because they are sensitive and specific, are one that you can do is the fecal occult blood, FOBT, where you do the 3 cards that you do at home. Some people still do those. It's 3 samples on 3 different days, but they have to be done yearly, okay? They have to be done appropriately. They have to be sent to the lab and not taken all over Huntington in your hot car for 3 days. And they have to be done yearly, okay? They're sensitive, their specificity is still lower, okay? Another one that we do here now is called a fit test. And that's where you get that little kit and it's got the little thing that looks like a little thing of bubbles, like wedding bubbles that you can get. Those are not wedding bubbles, okay? And it tells you on there how to do the tests, okay? And you also bring that back to the lab, and the lab tests it. This one also is using DNA technology. The other one now that's out there mainstream for DNA technology is the Cologuard. I always spell this incorrectly. I don't think, is there a U? I can't remember.
I think so.
Cologuard.
You know how I feel about that.
Yes. Cologuard is where you collect a stool sample in a bucket, essentially, at your home. You mail it off, and then they test it looking with this DNA technology that they have now. None of these ever replace a colonoscopy, okay? Colonoscopy is always the #1 gold standard treatment option or surveillance screening option for early detection of colon cancer. It's another important thing to throw out there that a screening is not magic. A screening does not prevent anything. A screening detects things earlier, okay? Some women think, well, I had a mammogram once when I was whenever, or I'm getting this mammogram, I'm never gonna get breast cancer, or I want a pap smear every 6 months because I'm not gonna get cervical cancer. They're not preventing anything, they're detecting things earlier, okay? Even though we call it preventative medicine, what prevents it were those modifiable risk factors. Not smoking, not drinking in excess, dietary changes, not being obese, those kinds of things, right? So we're detecting things earlier, and the gold standard #1 way to do that is to get your colonoscopy, okay? It's very highly sensitive and highly specific. If it is negative, it's recommended that you have another one in 10 years. So our screening guidelines, we're starting at age 50, right? Because why? 90% of them start after that. So there's no point in doing this on an asymptomatic 25-year-old person. Risk outweighs benefit, okay, at that point. Do 25-year-olds sometimes need colonoscopies? Yes, because there's several familial hereditary syndromes you can have. I have my own theories about HPV infection with that. If they're symptomatic, yes, but as a general rule for our basic screening guidelines, since the majority of cases are going to be over 50, we start at age 50. Age 45 for African Americans. Some institutes are saying starting at 45 for everybody, but we'll see how that plays out. Okay, and then you do it at age 50, and then how often? Every 10 years, okay? Up until you reach the point, and this is fun, who's going to predict this, who has a crystal ball, until your life expectancy is less than 10 years. So somebody do that math. So you start at 50, so you get one at 60, one at 70, and then typically now we've kind of put 75 as that magic age, where we kind of stop doing stuff, PAPs and mammograms and colonoscopies and that kind of stuff. But I have patients in their 80s who still get colonoscopies because they are very healthy otherwise, high functioning, and they've had colon cancer before. So they still need to have their surveillance, okay? Okay. So the word surveillance then means we find something. Okay, now what are we going to do? So the things that we're looking for is if we find a polyp, they need to test that polyp, right? And this is why it's important. This is one of the reasons, besides the fact that you're all gorked out of your head after you have a colonoscopy with anesthesia and all that, you need somebody that's there paying attention to what the doctor says after you leave, after you're done, okay? Because they're going to say, hey, we found nothing, come back in 10 years, then you'll get a letter in the mail. Okay, you should get a follow-up letter. Or, hey, we found something, we're waiting on pathology to come back, and we'll be letting you know, you'll be getting a letter in the mail, and then let you know what you need to do, okay? Because sometimes those polyps come back hyperplastic and benign, and then it's 10 years. Or it's an adenoma, and then it's 5. Or if you have a family history, typically it's every 5 years that you're going to keep doing these colonoscopies, okay? So we're going to look at what they found the last time. So if you have a polyp and what type it is, right? Your family history. And then I like to also remind people about change in history. Patient has a colonoscopy, it's been 6 or 7 years. My brother just got diagnosed with colon cancer. Oh, well, we needed to get you in now. Or even if now dad's 70 and he just got colon cancer, well, you need to have a colonoscopy sooner because now you fall into that category of having a first-degree family member that has colon cancer. Or a personal history. I just found out I have Crohn's. Then you're going to go into a different surveillance category as to when you need to have these colonoscopies, okay? So that's kind of the lowdown on colon cancer and getting your colonoscopies done. We don't necessarily want to do them any more frequently than this because of those risk factors, but the main one being a perforation of the colon. And we don't want to be in there doing that test if we don't have to be, if there's not a clear indication for doing it. Of course, risk with anesthesia, things like that. Also, as we get older and we tend to be on more medicines, if you are on blood thinners for other health issues, that's a whole other issue. You all know that. You have to stop your medications. If you're on Coumadin, a lot of times we have to bridge you with injectable medications. And then the surgeons really don't like when you're laying there on the table, oh, I took my Plavix this morning. That really kind of messes up their day. Or I didn't take all my prep, and that's the other thing. If you're not going to take the prep, which the prep is the worst, right? The prep is the worst. But if you're not going to take the prep, it's not going to be worthwhile because the surgeon's not going to be able to see anything, or the gastroenterologist. And they really don't like to put their scope in there when you haven't finished your prep. That makes for a bad day too. Shannon can attest to that, I'm sure. So that's pretty much my spiel. Anybody with any questions right off the top of your head you can think of? Hopefully that made sense, a little bit more logical as to why we do things the way that we do them. So if somebody they've had their colonoscopies, if they've been normal or whatever, now they're 80, the risk would outweigh the benefit of then having this test done because the risk of perforation, again, the interactions or issues with their other medications, life expectancy, they may live another 20 years, but it's not worth putting them through the risk if their other ones have been normal.
Well, hello everyone. Most people know me. For those that don't, I'm Shannon. I am a registered nurse with the Endoscopy Center in the Gastroenterology Department. We do procedures here 5 days a week, have 3 physicians usually running every day. We do an estimated 350 to 400 procedures per month, and that includes upper endoscopies. I'm basically here to talk to you about what happens during procedures and what to do to get ready for procedure. That's the big thing that seems like we're going through now. We've got a lot of new preparations that are out. I have them displayed up here, all the ones that are offered. Well, most of them that are offered that we use. The key to a good preparation, does anybody have any clue what that is?
Follow the instructions.
Follow the instructions is always great. Lots of fluids the day before your test. The more fluids you take in on your own, the better the prep is going to work. I think one of the handouts recommends like 12 glasses of clear fluids. I don't think that's enough. I think the more you take in, the better you do. Options for the prep. We have the standard, the gallon prep, which everybody absolutely loves. And it actually is it actually is one of the best preps we have as far as results. We have 3 others that are split dose prep. They are low volume. They don't have a bad flavor. They take part of it at one time, the second dose a few hours later. Actually, we've tried all of them ourselves, and actually not bad at all. Again, clear liquids added to that. A lot of people come in and think they've gotten one part of it down and they're going to the bathroom and it's nice and runny, and not good enough. Yeah, we want you coming out clear. We want both preps down. You get in there to be able to see, and it could be liquid, but there's still too much liquid to do the test. You're you're dodging things, and it's just not a good idea to do that, and it's a waste of your time, waste of doctor time, and we want to get good results for you. Things we look for the test. We look for polyps, we look for cancers, we look for bleeding, we look for hemorrhoids, we look for diverticulosis. All those things we can see during procedure. We get you ready. You come into the office, nothing to eat or drink after midnight. You come in, check in, and the girls in pre-registry or pre-procedure take you back. We start you in IV. We use Demerol and Versed for sedation. It is IV conscious sedation. It is not a deep sedation. We consider it like a twilight. It is, a lot of people get that confused because they think we're going to put them to sleep, and that's not actually the case. A lot of people do sleep all the way through it. Some people stay wide awake and watch the screen and can tell us everything that happened. But our goal is to make you comfortable during the test. Sometimes that's not possible, no matter how much medicine we give you. Sometimes the anatomy is different for everybody, and if you're not comfortable, we will stop the test and reschedule you at the hospital with a deeper sedation. But sometimes you don't know that until we get you in there. During the test, it takes about 10 to 30 minutes. Again, depending on anatomy, depending on sedation, depending on prep. Our standard is to spend at least 6 minutes on the withdrawal time of the scope to look, make sure we're seeing everything, we're seeing all the surfaces. I do have a picture. Sorry, I know y'all have just eaten. So this is the colon. Whenever we go to the colon for the procedure, our goal is to get here to the cecum, and this is where your appendix is located. It's where the small bowel comes into the colon. So this is where we want to get to. We start here, we go all the way up, across, and down. So sometimes that's a simple task, sometimes not so much. But again, we want to spend at least 6 minutes on the way out, making sure we're looking at the surfaces, making sure we're not missing anything. Again, if you don't prep well, that's where that comes in. You know, we could miss things. We could miss polyps. We could miss lesions. You know, something very easily could be missed with that. Again, the test takes between 10 to 30 minutes. You will go to recovery after the test. That is the fun part of your day. That is our toot room. So during the test, the doctor inflates the colon with air to be able to see. The colon is like a balloon. It's flat unless there's something in there. So to be able to see, you have to expand that to see all the surface of the walls. So we use air. So when you get to recovery, all that we want you to start expelling. You can stimulate a nerve called the vagus nerve. If you do not pass that air, it'll cramp you up, make your blood pressure drop, make you sick to your stomach, sweaty. We've had people pass out. So the more air you get rid of during recovery time, the better you'll feel after you leave. Once you leave, you are not to drive the rest of the day. You are to take it easy, simply because of the sedation effects that could linger throughout the day. So that's why it's important to bring a driver with you for the procedure and just to plan the day off. Had somebody yesterday wanted to go home and watch their 2-year-old granddaughter. Like, not a good idea. So the driver had to stay with him that day and help babysit. So, and then the next day, we usually call and check on you, make sure everything goes okay. Some of the complications that we have from the procedure, again, perforation is the major complication. We usually know this immediately if it happens, sometimes not if it's something very small. That's why it's important for us to call you the next day and check on you. That's why we instruct you ahead of time. You know, if you have any problems after you leave, severe pain, abdominal distension that doesn't go away, fever, chills, you are to call us. Okay? Bleeding. If we take biopsies or polyps off, bleeding is a big risk factor. Yes. Especially if someone's on anticoagulants. That's why it's important to talk to your doctor ahead of time. Make sure that those get stopped or held or bridged, if possible. I think that's all the side effects or risk after the test. I don't know what else to talk about. I was just rambling and then it's gone. Does anybody have any questions? Polyps that come up. I mean, I know you went over the polyps in the 10-year repeat, but if someone does have polyps, if someone does have a family history, those two combinations bring patients back quicker. Usually it's about a 3 to 5 year repeat colonoscopy, and then also a change in yourself. If you start seeing blood, if you start having a change in bowel habits, if abdominal pain, of course, it's not a set time you come back. It's based on your symptoms, so we can have you back in sooner if needed. Anything else? Any questions? I have lots of stuff over here for display. I have the bowel preps. I have information on what to expect for colonoscopy. I have some pens I gathered up. I could only find one extra poop troop pen. I've got the Cologuard. She talked about the Cologuard that gets mailed in. This is the kit. They mail it to you. You fill it up, send it back in, and your doctor gets the report. I actually have a scope up here if anybody wants to see what the colonoscope looks like. And this is what we use for procedure. The colonoscope is about 5.5, 6 foot long. Your colon is only 3 to 4 foot. So this is not, it can be all used. It depends on anatomy. It depends on looping. So that's why the extra length is there. But usually you don't need all that. The tip has a camera. This is the tip that gets inserted. Has a camera. It also has openings for water, for suction, and for air. So the doctor is able to control from here. This is his handpiece. And he is able to move this to navigate through the colon. And he can move it side to side, up and down. And we're watching TV screens. And it's showing everything on the screen that the doctor is seeing. So this is how we are able to look in the colon.